Hi, everybody, and welcome to tonight's webinar on women's health beyond family planning. My name is Stacy Watson. I'm the director of the LDS division at the Marfan Foundation, and we are so excited that you took the time to be here and so grateful to our wonderful panelists and the rest of the team at the Marfan Foundation for helping us put this together tonight. We want to encourage you to use the question and answer feature of the webinar with your questions so we can keep track of questions that are being asked. Many people submitted questions in advance, which our panel has and are hopefully going to be able to get to an answer tonight. Thank you so much for being here. I'm going to turn it over to Michael Weimer, our CEO, to share a few words and welcome you as well.
Thanks, Stacy. Good evening, everyone. It's a pleasure to stop by and say hello. Also, thank Dr. Russo and the members of our panel for spending time with the LDS community tonight discussing these important topics. I also wanted to take just a few moments to thank Stacy and the members of our LDS steering committee for their leadership. I know I speak for the entire Marfan volunteer staff team in thanking Stacy for her leadership of the division. Seems like she's been here a long time, but probably something like 8 or 9 months at this point in time. In those 8 or 9 months, though, she is, or will be, by the end of June, she'll have been to 8 Walks for Victory, Chicago and New York galas, and even squeezed in a meeting with our board of directors. So I think she may even have a political future in the years ahead. But, you know, Stacy, again, thank you very much for your leadership. During this time, we've also established a new LDS International Connect support group. That group met earlier this week. The initial meeting had 20 participants, and that was from Ireland, New Zealand, Cyprus, Croatia, Switzerland, and Mexico. So again, Stacy, thank you, and thank you for your help with this as well. Now I have the pleasure of introducing one of our favorite physicians, a member of our professional advisory board, and also a grant recipient from the Marfan Foundation, Dr. Melissa Russo. Melissa is a maternal fetal medicine and clinical genetics specialist in the Division of Maternal Fetal Medicine at Women's Infants Hospital of Rhode Island. Melissa, it's all yours.
Thank you. So for those of you that do or don't know me, so I mostly do stuff with pregnancy and have done a lot of stuff with pregnancy with the foundation. And there's just been a lot of need, I think, to go beyond talking about pregnancy in terms of women's health and gynecological care and talking about things. And so that is not my expertise. And so I gathered a bunch of my colleagues and friends who are amazing. And we're going to be just giving you some background about some women's health issues and then really open up the floor for people to ask questions. Can you go to the next slide? Or actually, wait, stay here for 1 second. That's the pictures of everybody I forgot to introduce, sorry. Okay, so just to give you guys an introduction of our panelists. So first is Dr. Rebecca Allen. She works at Women and Infants Hospital with me in Providence, Rhode Island. She is an OBGYN and she has special expertise in family planning. So she does stuff with contraceptive care. She does teaching at the hospital and lots of different things related to gynecological care. And then Christine Foley is also one of our physicians who is at Women and Infants Hospital. She is an OBGYN and she has expertise and she has a laparoscopy fellowship and she has expertise sort of in lots of things, but the main thing she's here to help with tonight is pelvic pain and sort of the workup for that and talking about things that can cause pelvic pain. And then Dr. Kate Zalewski is at Women and Infants Hospital as well. And she has expertise in menopause care. And then Dr. Kristen Madison used to work with us at Women and Infants and now is at UMass in Massachusetts. And she has expertise really in abnormal uterine bleeding patterns and has done research in things like looking at different treatments for abnormal uterine bleeding. So I just want to give a special thanks to all of these women donating their time, and they're going to talk to you a little bit tonight and answer your questions. Next slide. So with this webinar, we're going to be talking really about Loeys-Dietz syndrome, talking about gynecological issues. We're going to overview some common problems and then discuss potential management strategies and provide tools for you to go to your own physicians to get help with your health care. Next slide. And so I just wanted to give one intro slide talking about this, that really what I hear across the board from a lot of people that have genetic conditions where they're at risk for aortic aneurysm and dissection is that hormones are bad. And we sometimes will use hormones for the care of these problems. And this really stems from research that we know that pregnancy is a higher risk time where we have increased hormones like estrogen and progesterone. And there's a higher risk time for cardiovascular events during pregnancy. But there's really not a lot of data out there to say that these hormones are bad. There's just association. There's not great animal data or anything. And so really the point of this is to say that we're going to talk about times maybe you consider hormones or not. And there's not really a right answer for all, but just sometimes that can be involved in the care for some of these issues. The other thing I hear a lot with these conditions is I have Loeys-Dietz syndrome, and therefore that means that's why I have heavier periods. And that's not necessarily true either. We don't really know that. And I think people will attribute these things to the fact that you have a genetic condition. And we just really need to be doing more research to figure those things out. And so someone should just first look at you as an entire person and do the same type of workup that you'd be doing for any other person that has these issues. And I think too, with this, there's been a lot of research and money mainly focused on cardiovascular health because of the potential events and things that can happen. But we're hoping that as we in the general population start investing more in women's health, that more research and things can be done in these disorders related to women's health issues. Next slide. And so this is just a general overview, of course, not encompassing everything, but sometimes we would use hormones in women's health disorders for pelvic pain issues, for menopause, for birth control, endometriosis, abnormal uterine bleeding. And so these are just some of the things that we're going to touch on a little bit more as we go through some introductory slides. Next slide. I'm going to hand this over to Dr. Allen.
Great, thank you. I just wanted to give a quick overview at the beginning about different contraceptive medications and whether or not they're safe for patients with certain medical conditions. We use guidelines from the World Health Organization and Centers for Disease Control that let us know what methods are safe for people with certain medical conditions. Now, of course, there isn't a category of patients with Loeys-Dietz syndrome in this guideline. It's just too rare, and there's not enough research and data to guide what, is the best contraceptive for that population. But there may be some conditions that you develop as a result of having Loeys-Dietz syndrome. Or are associated with it, or just other conditions that we may want to take a look at when we're looking at if you're a candidate for different hormones. And we use hormones in gynecology, not just for contraception, but also to treat abnormal uterine bleeding and a lot of other conditions. So this is not just for contraception. And with this table, you'll see a theme in that for most of these conditions, whether you have high blood pressure or have had a blood clot, whether you have a mechanical heart valve or have suffered a stroke or heart attack or have migraines with aura, most progestin-only methods are considered safe for you. And these include progestin-only pills. There's a progestin-only implant. and an injectable that are on the market. And then, of course, we have the intrauterine devices or IUDs that are also considered very safe. And oftentimes we like IUDs because they tend to act locally in the uterus. Of course, the copper IUD contains no hormones, so that is definitely safe for everybody. And the progestin IUD acts locally at the uterus. Very little of that hormone is absorbed into the body. So IUDs are definitely one of the safest methods of birth control. And then you'll see that the estrogen-containing methods, whether it's the pill, the patch, or the ring, are often more contraindicated in patients with these disorders. So there may be times when, a doctor will tell you where I don't think you're a good candidate for taking estrogen at this time because of another disorder that you have. And I think that's pretty much it, just to give kind of an overview on contraceptive hormones.
Thanks. Go ahead.
Hi, everybody. I'm Kristen Madison, and as Melissa had mentioned, I really like talking about abnormal uterine bleeding and heavy menses. But to talk about abnormal periods, I think we first should talk about what normal menstrual bleeding is and how it works. One thing I did just realize is I think I made it really challenging for Stacy because I rely very heavily on slide animation when I'm explaining complicated topics. So Stacy, I think I'll just say the word next when you need to click the button so we can move through the animation, but I'm sorry about that as we're doing this. But it's the best way to get through some of these topics, especially when we go to talk about the different steps of the menstrual cycle. So talking about mechanisms of menstrual flow, a normal menstrual cycle is coordinated, synchronous bleeding, and cessation of bleeding. And it requires a highly regulated sequence of molecular, cellular, and vascular events. And for a regular period, a normal period, you have to have a normal uterine lining and cavity and a very specific exposure and timed exposure of the uterine lining to hormones. And the two main hormones are estrogen and progesterone. Next slide, please. So let's walk through how we get there in terms of getting the hormones to the uterus that are going to tell the bleeding to start and stop. And it actually starts here with the pituitary gland and the hypothalamus. So the hypothalamus is a small cone-shaped region of the brain that contains a control center for many functions of the nervous system and endocrine or hormone system. In terms of the menstrual cycle, it sends pulses of a hormone, gonadotropin-releasing hormone, to the front of the pituitary gland. You may hear the term hypothalamic pituitary ovarian axis, and that means the coordinated interaction between the hypothalamus and the pituitary. The pituitary sits just below the hypothalamus. This master gland releases hormones into the bloodstream that regulate all of the other endocrine glands. So it regulates the thyroid, the adrenal glands, and the ovaries. And responses to the pulses of hormones from the hypothalamus, the pituitary secretes a hormone that acts on the ovary. So you have the hypothalamus, the pituitary, and the ovary working together. And it's the interaction of these three structures that essentially coordinate the sequence of events that leads to a normal period. Next slide, please. You have two ovaries, and the main function are to produce eggs and female hormones. You have cyclic production of eggs, and related hormone production relates the growth and the shedding and the lining of the uterus. And then you have the uterus, which is a pear-shaped muscular organ that functions to support a fertilized egg in pregnancy. And the lining of the uterus, the endometrium, responds to the cyclically released ovarian hormones. So you have the hypothalamus, the pituitary, the ovaries, and the uterus. Next slide, please. So this hypothalamus pituitary ovarian interaction controls ovulation and then ovary hormone production. And then the lining of the uterus responds to the hormones from the ovaries. So when I'm talking to patients about abnormal uterine bleeding, basically they tell them that the lining of the uterus only does what the ovaries tell it to do. And the ovaries do what the brain tells it to do. So the uterus and the lining of the uterus are only reacting to the hormones that are produced by the ovaries. Next slide, please. So let's break down the menstrual cycle. Next slide, please. Right, so let me figure out how to get through this without the animation. Give me 1 second. So in a normal
If
menstrual
you give me
cycle,
a moment, I could pull up that animation. I'm sorry, I didn't realize that when I
no
when I
worries.
put everything together. So hold on just a moment.
Yeah, this is one that has so many things going on that you really have to show the things step by step.
We will get that. Okay. Is this the graph? Hold on, I'm gonna share and then you can
The one
make
with all the circles and the rectangles and the picture and all the stuff.
Here we go. Can that be seen well? Here it goes.
Okay.
Can you see the movement happening?
We can, let's, yeah, why don't we go back to the static one and I'll just walk everybody through it.
Here or
Or the presentation that you'd had up before.
okay, just a moment. Here we go.
Perfect. So for a normal menstrual cycle, you can see all the way over on the side, cycle day 1 is when the bleeding begins. And so cycle day 1 is on when the bleeding begins, and that happens in response to the withdrawal of estrogen and progesterone. So day 1 of a menstrual cycle is the first day of bleeding. Next, what happens is that the ovaries produce estrogen alone. So you can see in the top, the purple box. In the ovary, you produce estrogen alone. What happens in the lining of the uterus when the ovary produces the estrogen alone is you have healing, which stops the bleeding, and growth of the lining of the uterus. Next, what happens, you can see how we move over to the yellow part of the diagram. You have the ovary producing estrogen and progesterone after ovulation. When estrogen and progesterone are secreted by the ovary, you end up with gland development within the lining of the uterus, which stabilizes the lining. And then you move on to the pink box, which is withdrawal of the estrogen and progesterone. And that translates, again, to the shedding of the lining of the uterus, which moves you back to day 1 of the menstrual cycle where bleeding begins. So in the endometrium, it's exposed to the estrogen alone first, which heals the lining of the uterus and stops the bleeding. And then it causes the lining to grow. And then estrogen and progesterone causes gland development. And then when a pregnancy doesn't occur, estrogen and progesterone stop being produced and the lining sheds. So menstruation in this context is a simultaneous universal endometrial event. Next slide, please. So normal menstrual patterns are bleeding from the uterine endometrium in response to the interaction of the hypothalamus, pituitary, ovaries, and uterus. And I'll say that multiple times. Typically, bleeding lasts for 4.5 to 8 days. The amount is stated as 30 milliliters of blood loss, but it's really that it doesn't interfere with quality of life. The interval from the first day of one period to the first day of the next is 24 days to 38 days. In terms of regularity, it's generally predictable. So an individual's cycle length tends to be the same from cycle to cycle. Next slide, please. Abnormal uterine bleeding is super common, and it happens in up to 30% of menstruators. And anything that interferes with the hormone cycle that we've mentioned, the lining of the uterus, the blood vessels, or blood clotting can lead to abnormal bleeding. There can be a problem with volume, which would be heavy menstrual bleeding, or a problem with predictability, which is irregular uterine bleeding. And I wanted to mention that after menopause, all uterine bleeding is considered abnormal and should be evaluated. Next slide, please. How you actually treat abnormal uterine bleeding depends on the cause of the symptom. So there's multiple different causes. So I'd said anything that interferes with the uterine cavity can cause abnormal bleeding. That would include things like polyps, adenomyosis, fibroids, precancer and cancer changes, or coagulation problems, problems with ovulation, problems with the lining of the uterus in terms of its ability to clot, medications that individuals might be on, and then an area that we haven't necessarily classified all the problems. And the best treatment for the individual is based on some of their other medical problems and contraindications and what we think is causing the symptom of abnormal bleeding. Abnormal uterine bleeding isn't a diagnosis on its own, but it's a symptom, and you have to think about what's the cause or contributor of that symptom. Next slide, please. So all of the treatments that Dr. Allen had presented, the medical treatments, the combined hormonal contraceptives, the progestin IUD, the progestin-only pills, those are often used for treating abnormal uterine bleeding. And so the same things apply in terms of the types of patients who can or can't take hormones in terms of treating their abnormal uterine bleeding. It is very dependent, not just on having Loeys-Dietz, but the other medical conditions an individual might have, like heart disease, valve transplant, history of blood clot or stroke, or history of migraines with aura. The thing I wanted to focus on here, though, is that it's not one size fits all. And for some individuals, if they have a structural problem, like they have a uterine fibroid or they have an endometrial polyp, they should probably have that evaluated, because the treatment would be potentially removing the polyps surgically or removing the fibroids surgically, or considering other treatments for the fibroids, like a procedure that clots off the blood vessels to the fibroids or uses some energy to destroy the fibroids. But for patients who have either irregular bleeding because they're not ovulating regularly, or have heavy bleeding because the lining of the uterus doesn't clot appropriately, progestin-containing IUDs, combined hormonal contraceptives, progestin-only pills, nonsteroidal anti-inflammatory agents like ibuprofen, tranexamic acid, and then endometrial ablation are all treatment options. Next slide, please. I think that's my last slide, and that's it.
Okay, I just wanted to reintroduce Dr. Foley, or Christine's going to talk to us next. And she is actually, I said that she's a laparoscopy specialist, but she actually did a minimally invasive gynecology fellowship. Let's go ahead, Christine.
Perfect. Thanks for having me. So I just wanted to talk a little bit about chronic pelvic pain and kind of how you figure out what could be the source of the pain that you're experiencing. If you're experiencing pain, is it related to your gynecologic organs? And what is the source of your distress? There's a big difference between chronic pelvic pain and cyclic pelvic pain, and that's an important thing to think about when you are kind of seeking treatment and figuring out who the best provider will be to help you. Cyclic pelvic pain, or also known as dysmenorrhea, is pain that either precedes the period or precedes your bleeding and then occurs with your bleeding, with less pain intervals between cycles, as opposed to chronic pelvic pain is ACOG defines it as at least 6 months of pain that persists even despite your cycles. So pain that it occurs between your periods. And that's a really important distinction because while they can be interrelated and cyclic pain can lead to chronic pelvic pain, they oftentimes have different organ systems involved and different treatment options. So one of the best things that you can do if you are experiencing pain is to start with a pain diary to really map out when you're having pain, what are your triggers, food triggers, activity triggers, menstrual triggers, and that can help kind of clue you into who may be best to help you. We can go to the next slide. So there are, as I alluded to, there are many different organ systems that can be involved in chronic pelvic pain. And it affects a large proportion of patients. In the general population, up to like 20 to 40% of patients. And of those, 80% don't have a definitive reason at the end of the day, but there are a lot of comorbid overlapping conditions that can contribute to your symptoms. The most common ones in the areas that I specialize in specifically are endometriosis, which is where that lining of the uterus that Dr. Madison just so beautifully explained where it comes from, starts to grow into the pelvis and on the organs of the pelvis, including the lining, sometimes the intestines, the bladder, the ovaries. And that disease is highlighted by pain that really precedes the menstrual cycle, pain with any vaginal penetration, like deeper penetration, and pain with bowel movements, especially during your period. Those are kind of like the highlight symptoms, the worry symptoms of endometriosis. It is associated with missing school, missing work, really interfering with your quality of life, and can also have impact on fertility. And it's very common in the general population. There's only one published abstract on the relationship of LDS and endometriosis, and they said that the incidence of endometriosis, both in Marfan's and in this, are essentially the same as the general population. But that was, again, an area for future research and just one small isolated study, actually out of your foundation by surveying the patients here. So thank you for participating. Other common reasons for chronic pelvic pain include pelvic floor dysfunction, or also you may hear it called like levator spasm. The pelvic floor is an intricate network of nerves and muscles that encompass the rectum, near the bladder, the vagina, the uterus. They attach to the hips and the back, and pain in these muscle systems can be triggered just like if you have pain in your back or pain in your shoulders. And essentially when you have experienced pain over time, that pain can become constant and those muscles become too tight. And that is best treated through pelvic floor physical therapy, yoga, acupuncture, muscle relaxants in the appropriate patients, and is a very common source of pelvic pain, especially pain that's like worse at the end of the day, worse with long periods of sitting or standing, worse after childbirth or any trauma. Worse after like chronic UTIs. There's a number of triggers that can cause those muscles and nerves to kind of go into spasm. And then the third kind of overarching general topic that we talk about is like overlapping conditions from other organ systems. So irritable bowel syndrome, painful bladder syndrome, both of those conditions have high sensitivity in the nerves, and are like pro-inflammatory conditions that can cause pain with urination, pain with the full bladder, painful bowel movements, constipation, diarrhea. And the pelvis is complex because there's multiple organ systems there, so it's hard to pinpoint exactly which condition may be contributing to your symptoms. But the general treatment is sometimes there's a role for menstrual suppression, similar to what Dr. Allen and Dr. Madison talked about. Also for physical therapy, mindfulness, acupuncture, muscle relaxants, non-steroidal inflammatory medications, non-steroidal inflammatory supplements and diets, dietary modification, and then certainly surgery in the appropriate patient. Next slide. So if you're experiencing some of these symptoms, it's best to either start with your primary care doctor or your gynecologist. And that really depends on what the driver is. If it's mostly pain that is related to your menstrual cycle, then perhaps your gynecologist would be the right person. If it's mostly pain and bloating with certain food intake and it seems to get better after having a bowel movement, then perhaps your general PCP. But with chronic pelvic pain, there's very limited lab tests that are actually recommended. In pelvic ultrasound or in imaging to look at your colonoscopy, maybe a upper endoscopy looks at the upper abdomen, but it really comes down to a focused like history and physical and really figuring out what parts of the body are, have trigger pain on exam and how we can target that based off of your symptoms in your exam. If endometriosis is suspected and your pain does not get better despite hormonal suppression, then there can be a role for surgery. But conservative treatment is recommended to start. Go to the next slide. Yes, and then like this slide, and this slide is like what we do every day and what but the truth of it is that it's really individualized to every single person and really talking through what their goals are, how much distress they're having, really partnering with the patient and other non-gynecologists, such as your gastrointestinal team, your physical therapist. Your cognitive behavioral therapy plays a huge role in the treatment of chronic pelvic pain. Chronic pain doctors, your urogynecologists, just to kind of figure out the optimal treatment plan for you because it is very individualized. Next slide. Great.
We're up.
All right, so I'm here to talk about menopause. This diagnosis is made when a patient hasn't had a period for 12 months. So it's oftentimes a retrospective diagnosis, thinking back, hey, when was my last period? If it was 12 months or more ago, then the patient is in menopause. The average age in the United States is between 51 and 52 years, but the range of normal is great. So this can happen in pretty much between ages 40 and 60. And the reason for menopause is that the ovaries have a finite number of follicles and they run out of follicles. So there's no more of that ovulation event that Dr. Madison talked about. So there's no more signal to the uterus to bleed. So as she noted, any vaginal bleeding after menopause, after there's not been a period for 12 months, is considered abnormal and should be looked into. There are so many symptoms that have been evaluated and found to be related to hormonal withdrawal at the time of menopause. I think kind of maybe the most famous one is hot flashes, but that can also lead to issues with sleep, and that can lead to brain fog, difficulty concentrating. A number of these other symptoms that you see are probably related to frequency of vasomotor symptoms. But there certainly are others that have been studied and found to be related. And this is why when we'll talk on the next slide about treatment options, hormone treatment is attractive to a lot of patients because it can help with some of the other symptoms potentially, but the only indications that the FDA has given for hormone therapy are the vasomotor symptoms, premature menopause because of ovarian insufficiency, so before age 40, or if somebody had to have their ovaries removed, for example, local treatment in the vagina for some of those vaginal symptoms, and osteoporosis prevention. So in patients who are otherwise having a lot of symptoms and are at risk for osteoporosis, that might be a reason to choose hormonal therapy. So if you go to the next slide. So hormone therapy has a lot of similar contraindications as with hormonal use for contraception as well. So definitely someone with unexplained vaginal bleeding or history of a hormone-sensitive cancer, such as breast or uterine cancer, those would not be good candidates for hormone therapy. Someone with liver disease, and then patients who have increased risk of getting blood clots, so thromboembolic disease, those are not good patients for hormone therapy. But thankfully, we do have other options especially for treating those vasomotor symptoms that can be so related to a lot of the other symptoms that patients have. There is an evidence basis for the things in the tan and the pink boxes. So non-pharmacologic clinical hypnosis and cognitive behavioral therapy, there's actually excellent data to say that they are helpful in helping patients to have fewer and to manage the hot flashes that they do have. And then weight loss has a little bit less of an evidence basis, but definitely is something that we can discuss with patients. And in general, self-care is a great kind of thing to discuss with patients too, because good sleep hygiene, taking good care with diet and exercise are also really important parts of managing the menopausal transition. And then there are medications that we know can really help with hot flashes quite a bit. So fezolinetant is a newer one on the market. It is a medication that we can use in most patients, unless they have severe end-stage liver or renal disease, kidney disease. So that's a very promising drug that has been out, and it really just helps specifically with hot flashes, and really can be used in a lot of patients that otherwise, we would have a harder time treating. Gabapentin is another drug that is really helpful to manage hot flashes. It is sedating, so that may be beneficial to patients who are having a hard time with sleep as well, but can kind of be a downside as well, because the dose usually has to be titrated relatively high to help with vasomotor symptoms. Oxybutynin, which is a medication that actually helps with overactive bladder, has been found as well to be helpful. And then probably the most popular right now pharmacologic therapy that's not hormonal would be antidepressant medications. So SSRIs and SNRIs are very helpful for decreasing the number of hot flashes and helping kind of with that sleep modification as well. And then stellate ganglion block, which is a procedure that can be performed. There's less evidence to support, but that is definitely on the list of pharmacologic options. For patients who are primarily having vaginal symptoms, so sometimes the vasomotor symptoms will be the first symptoms for patients to have, and keep in mind, not all patients have them. Definitely, there are a lot of people who go through the menopausal transition and don't experience those hot flashes, but later on, the farther away from that last period patients get, the more likely they may be to have vaginal symptoms. And oftentimes this is the most surprising symptom for a lot of my patients. So the vaginal symptoms can present as vaginal dryness, vaginal discomfort, feeling like they have a vaginal infection. So symptoms like discharge and irritation. Some patients will have described pain with sex when they never have experienced that before. Other patients will have urinary symptoms, so more frequent urinary tract infections, or the sensation of having a urinary tract infection without actually having an infection. And so, especially if patients are only experiencing these symptoms, we tend to go to just this local treatment. So vaginal estrogen is the gold standard. It is the thing that will help all patients with this problem. And unfortunately, there may be some patients for which systemic hormone therapy is contraindicated, but there are many patients that, if you speak to your doctor, you may decide through shared decision-making that is a good choice for you, especially if you haven't had improvement with things like lubricants during sex, or vaginal moisturizers, which are specific moisturizers that you can buy over the counter that are specially formulated for the vagina to help with those symptoms like dryness or discomfort with urination. And I think that's it for my slides.
Okay, now is the time where we're really gonna open up the questions. So if people want to put stuff in the chat, we're happy to then have either Cece or Helene just read those questions to us, and then we can answer them as a panel.
Just a question in response to what we were just talking about, menopause. Is it typical for the symptoms that you were describing to come on suddenly or for them to progress slowly?
I think in general, I talk to patients about just the average, because everybody kind of everybody is a little bit different, but the average age is 51. And if that were the case, then the symptoms would kind of come on within like a year or two of that last menstrual period. So they would start actually before the end of the periods, and then they peak around the time of the last menstrual period or a year or two after, and then kind of trail off for a few years. So I usually describe it as like kind of a peak with a kind of a fast onset and a slower decline. The average amount of time in the United States that patients experience symptoms is 7 years, but we know that that varies really widely, and that there is quite a variation based on patients' like self-identified race. So there may be a role that, that racism plays in how patients have symptoms and experience symptoms. And so the symptoms tend to be more severe at the beginning, and, for the first year or two, and then trail off at the end. I can't say patients often complain about a sudden onset, but I wouldn't be surprised if it does happen for some patients.
Thank you. I'll go ahead and read from our chat. We have a question and then several coming in through the question and answer feature. It would be really helpful if you could use the question and answer feature. That way we don't lose anything in the chat. So the question is there any relation between recurrent pneumothoraces during menses and LDS?
I don't know that I don't know from an LDS perspective, but the most common reason for, can you hear me? Is there a delay? The most common reason for recurrent pneumothoraces during your menses is due to diaphragmatic endometriosis. So very rarely, but it can happen, there are endometriotic implants that implant on the muscle that helps your lungs work and separates the abdomen from the lungs. And oftentimes, in more advanced cases of endometriosis, those implants can start to have symptoms and cause recurrent, no, this is very rare, but cause recurrent pneumothoraces with your period. And if it is what they call a catecholamic pneumothorax, where there's actually blood within the pleural cavity, then that would be an indication that it was more of an endometriosis perspective, as opposed to if it was if there was not bleeding into the pleural cavity, then you may want to explore other reasons for cyclic pneumothoraces, but that is on your differential and something to talk about.
Thank you. Maggie asks, can the time just before menses begins cause an increase in pain overall in the body, not just in pelvic and reproductive organs?
I can answer that, I guess. I
Okay.
feel like that these people mentored me, so I have a little bit of imposter syndrome right now. But
I was typing answers to some of the questions, and so I couldn't hit the stop and mute button while I was trying to type some of the answers to all the questions coming in.
I'll give a very short perspective. So, having your period can be a pro-inflammatory state, and in patients who are, I think, have other inflammatory conditions, there are affiliated pain conditions that can worsen with your period. Migraines can become worse. Some people see changes to their bowel habits. You may hear that as like period poops. That's what they call it online. And some people have more sensitivity to their bladder symptoms as well, but it's individualized for every patient. But I'd love to hear Dr. Madison's response.
It was basically exactly that. But it can also be related to your uterus and pelvic structures, that it is very common for individuals to have pain mid-cycle, which is related to ovulation, and it has the fancy name called needle schmerz. But then to have cramping starting in the days leading up to the actual bleed, that some patients do have uterine cramping before the bleeding starts as well. But yeah, bowel symptoms, I think, are one of the really common things, and bowel cramping and change in bowel habits. And it's related to that whole hormone cycle that I tried to walk you through, that many tissues respond to the abrupt drop in estrogen and progesterone, but we don't know how much, and we don't have a ton of research in this area, not just thinking about Loeys-Dietz, but across the spectrum, because national organizations have not funded women's health appropriately.
Thank you. Before I move to the next question, does anybody else have a response from our panel? And I'm sorry about the background noise. No? Okay. Are women with connective tissue condition more prone to experience endometriosis? And if so, is that due to the laxity of ligaments that hold the uterus up? Doctors would make the comment about how far back my uterus was tilted. I suffered with painful endometriosis for many years.
And that's a great question. It's really limited by a few studies right now. In other connective tissue disorders such as Marfan's and Ehlers-Danlos, there is an overlapping patient's experience a little bit more pelvic pain, but their incidence of endometriosis when you actually do surgery is very similar to the general population. For the laxity, and it's understudied in most smaller populations, because in order to diagnose endometriosis, you have to have surgery or have some very specific imaging findings. So it makes that diagnosis really difficult, and makes large studies difficult. But in patients who have connective tissue disorders, there's also an increased risk of pelvic organ prolapse because of the laxity of the the laxity of the ligaments. And that is kind of related to your question, but that wouldn't be the reason for more endometriosis per se, but you can have laxity of the uterosacral ligaments and the ligaments that hold the pelvic structures in the abdominal cavity over time, and patients with connective tissue disorders have higher incidence of pelvic prolapse over time.
And actually, there's a question, a lot of questions we got before the webinar and one here tonight, about this in relation to, is there anything that we can do to prevent that prolapse? Is pelvic floor PT something that can be pursued to alleviate some of that?
So across the panel, we all have different specialties, but there's one area of specialty, and I was putting this in a couple of the answers here. Urogynecologist or pelvic floor disorders specialist really focus on pelvic floor disorders and the best management and treatment. And so I saw a couple of questions here, and I was about to answer them, where individuals have gotten different recommendations and opinions from urologists. I'd say that you should, rather than stopping there, if you're still suffering from symptoms of pelvic organ prolapse, urinary incontinence, or fecal incontinence, I'd recommend seeing a urogynecologist, because those are individuals who did 4 years of obstetrics and gynecology training and really focus on the pelvic organs and the pelvic floor. And then they do a 3-year fellowship specialized on solely pelvic organ prolapse, bladder symptoms, and the bowel symptoms associated with pelvic organ prolapse. So if you're suffering from those symptoms, I'd seek out that kind of specialist. Unfortunately, and maybe our urogynecology and pelvic organ prolapse specialists might know more here, but I don't believe there's anything that can be done to prevent pelvic organ prolapse. A couple of the risk factors that people talk about are cigarette smoking and chronic cough, are a couple of things that can predispose individuals to pelvic organ prolapse. So if you have a medical problem associated with chronic cough, getting that under control so you're not having as much chronic cough can be helpful. Chronic constipation is something else that can predispose individuals to pelvic organ prolapse. So working on bowel habits and working on regulating bowel movement so you're not constantly straining with constipation is something that might decrease the risk of pelvic organ prolapse. I don't know if anybody else knew any additional factors that can help prevent it, but I'd say see a urogynecologist if you're suffering from symptoms. Absolutely.
Thank you. Another common question that we are hearing about is if there are any special consideration for people with Loeys-Dietz for gynecological surgeries like hysterectomy, tubal ligation, etc. And another person asked similarly, with an upcoming hysterectomy being planned, what kind of complications should the surgeon be prepared for?
So-
I'm gonna let you talk about the surgery stuff. I mean, I think
Mhm.
in general with surgery, we know with vascular Ehlers-Danlos syndrome that people don't feel as well. And, the original talking about these conditions is you should avoid all kinds of surgery. And really, I think that's sort of being abandoned and not abandoned, but people are now operating on people with vascular EDS, but with Loeys-Dietz and Marfan syndrome, your connective tissues are different, but you usually can heal well from surgery. And so I'll let Dr. Foley sort of talk a little bit more about that.
My one comment was just like,
sorry, go ahead.
yeah, one thing in patients with EDS is, which is where most of my experience has been, is really with positioning. So making sure that, when you are having your surgery, but when you're awake, that you're in a position that is, safe and you're if you're prone to subluxation or to hypermobility, that you're in a safe position during that time, depending on how long your surgery will be. Any surgical candidate, we evaluate the indication for surgery and the risks specifically of general anesthesia, and really partnering with your cardiologist if you have one, to risk stratify where any individual may be, including like recent cardiac imaging, an echocardiogram, and kind of also like a functional status. We also know that patients who have chronic pain and are going into surgery will have a longer recovery and have more chronic pain after surgery. So preparing you for that journey and how to best heal during that process. I don't know if anyone else has any other.
Can you make a comment on like any kind of sutures or do you feel like there's differences with techniques? I mean, this is really, there's not evidence to say this stuff. So, I mean, I think we all really practice evidence-based medicine when we can, but as a surgeon, if any of you guys want to talk about how you would approach anything differently if somebody has a connective tissue. personally. Like,
I don't think I would change my practice. I know that patients are more likely to keloid or have cutaneous healing and scarring. But there is no like evidence-based interventions to prevent that at the time of surgery. It's a good surgical technique.
Robin says, in the figure, I think I saw that menopause can impact allergies. Can you elaborate? Is there a link to worsening allergies in folks with LDS with menopause or perimenopause?
Yeah, it's really interesting. The kind of lack of estrogen, so the ovary makes estrogen and progesterone both, but the lack of estrogen can lead to changes in pretty much every system of the body. So, you know, the most common symptoms again are going to be those like vasomotor symptoms and issues with sleep that come from the vasomotor symptoms. But patients definitely can notice changes in skin, changes in hair, changes in voice. You know, changes with allergies as well. I can't say that I understand the pathophysiology of it very well. The only thing that I can say for sure is that if you're a candidate for hormone therapy and you're considering hormone therapy, I tell my patients the only thing I can tell you for sure that will help with is the vasomotor symptoms and the things that are related to that. You may notice a difference in things like allergies if you go on hormone replacement, but that's not been proven. That's not been shown. So when it comes to a lot of those symptoms, I think really the strategy should be to try and treat the symptom, right? I'm not treating a hormone level. I'm treating a patient, and I'm treating that patient's symptoms. So if you're having more challenges with allergies, you know, you may need to consider some therapies to help with allergies. If you're having headaches related to the perimenopausal transition, then sometimes we need to just focus on the symptom. You know, knowing where it comes from it may be helpful, but at the end of the day, just really taking care of the symptoms that are bothering you is an important thing to do.
I think it's also important in this moment just to recognize the fact that there is a higher prevalence for environmental and food allergies among the LDS population. And there are studies actively happening right now to look more into that. So it's really interesting to hear that there can potentially be a connection there. I see one more open question in our question and answers, which is great. Is there any evidence that menopause lasts longer in women with Loeys-Dietz? My mom is 80 years old and still having hot flashes. I've had menopause 8 years and I'm still hot flashing. Not candidates for hormone therapy. Does dysautonomia impact hot flashes in people with Loeys-Dietz? So there were a number of different questions in there, but I'm hoping we can tackle some of that.
Sure. You know, we talk about the average length of symptoms, and definitely evidence shows in general that that there are people like on the far end of the bell curve that can experience hot flashes into their 70s and 80s. And why that is really unclear. There's not been like an identified risk factor for why people will have symptoms longer than other patients, but that's where we reach for the non-hormonal, you know, pharmacologic therapy if necessary. You know, and those other methods like cognitive behavioral therapy.
Thank you. There was just one more last submission right here. I hope I say this right, is Amicar okay to use to stop heavy bleeding?
I actually had to look it up because Amicar is aminocaproic acid, which is a treatment that's not available in the United States. In the United States, a similar medication that works under a similar mechanism is tranexamic acid. And what those do is they stabilize blood clots at the level of the lining of the uterus to make bleeding lighter. But with that, with the stabilizing of blood clots, one of the problems is the potential for increased blood clotting. And so say it's a good treatment for heavy menstrual bleeding, but whether or not it's appropriate for an individual depends on what their risk factor for blood clots are, and if they have a history of blood clots or predisposed to blood clots. So it's something that is a useful treatment for individuals with heavy and regular periods. And it's a treatment that is usually taken for about 5 days per month. But it's something that you'd have to talk to your doctor about to see what they think your individual risk is for blood clots based on your cardiac risk factors, whether or not you have something like atrial fibrillation, where blood clots might be a bigger issue, and whether or not you have a history of blood clots.
Thank you. Thank you so much. I just want to say on behalf of the Marfan Foundation, the Loeys-Dietz Syndrome Division, and the entire LDS community, how grateful we are for your time and expertise and wisdom and encouragement, truly. And thank you so much to Dr. Melissa Russo for really bringing this group together tonight. We really hope it's just the beginning of these conversations, and that we continue to talk about it. We continue to see more research. Before we pop off, I just want to let you all know about a couple of resources that are available to you. One is me. My name is Stacy Watson. If you have questions or want to get more connected to the LDS community, I would love to help you do that. You can find my email. I'll put it in the chat in just a moment, but it's swatson@loeysdietz.org. We also have an incredible help and resource center that you can reach at marfan.org/ask, and you will be responded to by incredible nurses. And that is just a fantastic resource for any individual questions that you might have, or if you have any, if you would like a connection to a doctor or a specialist, we can let you know who's nearby you. I also am going to do a little bit of a shameless plug. We love your feedback. It's so helpful. If you can take a few moments to do our survey and let us know what you thought about tonight, how it was helpful to you or not. We really appreciate it. And again, I'm just going to say thank you 1,000 million more times to all of the doctors and panelists that were here and all of our participants. It means so much to us. Thank you.
Thank you.
Thank you all so much. I'm trying to stop the recording so that it's
Thank you.